Welcome to everyone who's joining us for our webinar today on outcomes. We're looking here to talk about overcoming the challenges in IME and CME outcomes, and are we on the right track? And I'm joined today with my colleagues Monica Ghidinelli from the AO Foundation and Pan Chen from PeerVoice. And I want to say thank you to Pan, who's joining us from the US very, very early her time. I also want to say that we received quite a few very good questions that came in prior to the webinar. We will try to cover as many of them as possible today, but we may not get to all of them. So if you're able to, please do join us in Madrid in the first week of November for 17 ECF European CME Forum, where we will be having sessions talking exactly about outcomes. And so, and also you can come and join your peers and have further discussions with them. So without any further ado, we have a lot of questions today, and I'm going to just jump right into it. So, you know, many of us are familiar with Moore's levels and Moore's levels of outcomes, and that has become a bit of a standard of measurement for us within the medical education, continuing medical education sphere. But you know, Pan and Monica, in your opinion and in your experience, are we actually using Moore's levels outcomes of adequately? Are we really capturing the true impact of CME programs? And if not, what other frameworks or standards might also help us to provide a more complete picture of success? Pan, I'm going to throw this over to you for a second. If you'll take a moment to introduce yourself and then give us your thoughts on this.
Will do. Thanks, Celeste. So, hi everyone. I'm Pan Chen. I'm the Vice President of Educational Outcomes from PeerVoice. We're a global IME and CME provider. As Celeste mentioned, it's like 6 a.m. my time. I guess that shows my passion and my love to outcomes. So to answer this very great question, Celeste, I think it's a complex answer, and I would say both no and yes. I do believe Moore's model is a very thorough and comprehensive and helpful model in guiding our outcome evaluation. I think it's really thorough. And it has been, based on my observation, widely adopted across the board by different type of provider, by different type of supporter as well. As such, it really helps to standardize outcome evaluation. So we're all aiming to measure the same thing, and we're all speaking the same language when we talk about different level outcomes. So I think as such, if we introducing a different framework and try to set up different standards, it may not be ideal because it could make things even more challenging where people all do different things. So that's like why it's no. However, because it's so widely adopted, I do see a need actually, as of right now, to start delving deeper into the model, which means I think there's a strong need that we need to start reinterpret, expand, and then potentially bring in some additional framework to deepen our understanding of this model. So for instance, I think something that is frequently missed is Moore's model is actually intended as a guide for instructional design versus just an outcome assessment tool and model. So this means just because it has 7 levels does not necessarily mean we say all level they are measurable or could be measured in our community. That's not the case. However, it is important, like when you design the education, you have the goal in your mind, like whether you're trying to tackle patient health or like performance, you do need to have those goals in your mind in order to design the education properly. So I feel that part has not been adequately acknowledged. And the other part about the Moore's model is about like when we talk about knowledge and competence, we focus a lot on objective and subject measure, which is something we're going to cover today. However, in my opinion, it is about time we start to talk about what is standard for a good versus bad question versus just those ways we're going to measure them. So what kind of knowledge and competence measure can bring us insights that could shape future education that can help us learn and move forward? That's critical as well. And lastly, for higher level outcomes such as performance and above, I think this is a great opportunity where we can bring in more framework. Because I saw right now, given the pyramids, we kind of try to assume there's a direct link between education and then performance or patient health, but that's actually not the case most of the time. So we need to leverage additional framework. For instance, there's a COMBI model of behavior, there's trans-theoretical model, there's a sort of change logical model that can really help us kind of view those changes in behaviors as a holistic system and allow us to find out, okay, how can we get there? Knowing there's many steps in between, so we can focus our outcome evaluation not just on the end goal, but also on the intermediate stage that we were aiming to achieve. And I think if we do that, we can really set up more realistic and meaningful goal for those higher level outcomes.
Thank you.
Those are my
Thank
2
you.
cents.
Yeah. So thank you for that very clear explanation. Monica, can you first of all introduce yourself a little bit and then tell us your thoughts on using Moore's levels as our standards?
Hello, everybody. I am Monica. As you said, I'm the manager of education research, accreditation, and partnership at the AO Foundation. That is a non-for-profit organization focused on bone healing. And we work globally. And our organization is working and looking at outcomes, and we were using Moore's, we introduced Moore's level in 2010. So we are really passionate about outcome measure, and we are really attached to this model. So, but I agree completely with Pan that, I mean, there are other models. And what I want to emphasize is that every model has its own limitations. So for me, the advantage of using Moore is that is extensively used and is giving a common language that we can use among providers, but also with supporters and accreditors. And this is and we can communicate effectively and also have a common understanding.
Thank you. Thank you. Yeah, very good response. So, talking about continuing on the discussion about Moore's levels, there are 7 levels, and we start, with the lower levels, the participation, satisfaction, and then we get into, knowledge and competence, and then those higher levels of performance and community health. Um, when you're designing your outcomes evaluation, how do you decide which Moore's levels to apply? I mean, I think we've all seen, especially if for those of us who respond to RFPs from time to time, we're seeing, requests to have maybe, outcomes to levels 4 or level 5 or even sometimes beyond. But is that always practical to just pick? Or how do you go about, I guess is a better question, how do you go about choosing, which level to use? And are those higher levels always practical to be using to measure? Monica, I'm going to turn this one over to you because you do some very different types of programs as well as through being the society and through surgery and such.
So, I mean, this is the golden questions, right? So there are 3 key factors that you have to apply when deciding which Moore's level you choose. So the first thing is really, what is your education about? What is the goal, and what are the learning objectives? And the second one is, which are the resources that you have available? And the third one is, how feasible is to collect the data. So let's start with the first one, that is the learning objectives. So let's make it a little bit less theoretical, but more practical. So if you have an activity that is knowledge, so you have micro-learning or a 1-hour webinar is only about knowledge, then level 3 learning is the best fit. If you want to measure, if your activity is to increase the competence, then really you go for level 4, that is the competence. So are they able to show how to do something? But if the goal of your activity is to improve the performance, and you have, like we normally have a workshop where we are teaching technical skills, it's true, you want to look at the performance. Are they able to perform this on a patient? Then level 5 maybe is more adequate. But to look then at patient health, that is level 6, this is a little bit more challenging, right? But again, if the goal is to improve, and you then to prove this, the performance, then you can look at the patient and the community health. And this is what you have to target. So this is regarding the learning objectives. Then is the resources. If you have little resources, then it's easier to measure learning. So with standardized tests, and because the patient health and community health will require long follow-up and access to the data. So this comes to the feasibility. Are you having the access? So it's really feasible to get the patient data. If not, you cannot say that you have a level 6. Or what you can ask for is a self-reported, that we will touch later on subjective versus objective measures. Yeah. But again, so it's not always practical to aim for so we all aim our activity to have a better patient outcome, but it's very difficult to measure it. So it's not very practical. This is why aiming for lower levels maybe is more reliable and also cost effective for the provider.
Yeah, and you bring up some good point about patient health and patient data, and I think that's something that we should acknowledge, because we do have our audience comes from both Europe and the United States right now, and you know, in Europe we have very, very strict privacy laws, and really do restrict us in many ways from collecting the kind of the data that would really support a level, even sometimes a level 5, but definitely 6 and 7. That's something that we really can't is a challenge for us over here. And do you have any insights on that as well? You know, choosing the level of where our education needs to be.
Mm-hmm. So I think Monica, like, she summed it up really, really well, and I agree completely with whatever she has really summarized. But I echo, especially for her emphasis on resources and practical aspects. And one thing I want to emphasize is, like, I've heard a statement in the past where it says you cannot impact if you cannot measure. What I want to say is I actually disagree and have a different perspective on this. I strongly believe you can still impact even if you cannot measure. So what does that mean? We have to think about outcomes, right? They are also our goals. If you have an education aiming to change clinician behavior, but you cannot measure it, you should never give up that goal. You still need to design your education using evidence-based strategy to increase your chance to change the behavior, even though you cannot measure it. Right? So outcomes is not really the end goal, really the goal we define during our education design. That's the real goal. And as related to that, I feel like this also related to one of the questions we have seen, Celeste, about sample size. You have a question asked about what is the best sample size. Given the resource limitation we all have, I think it's also important to acknowledge, right? We should not set a bar there, like a minimum standard there, but we should all aim for the best sample size we're able to achieve, given the resources and time we're able to allocate to outcomes. But we should never prioritize outcomes over education. So I think that's a really important message, Monica, you are kind of getting out there. It's being realistic and try your best and really aiming, like focusing on the design and don't like really prioritizing outcomes over education design. I think that's a core message here.
And that is, and thank you, Pan, for that, because I think that that definitely we've had some discussions around that in the past about the education versus the measurement and the outcomes. And it really does lead us into my next question quite well, is, we often talk about subjective and objective measures. And and they're discussed in the context of CME. I will use the level 5 as an example. Do you have physical patient data to prove performance, or is it self-reported? And there's a lot of discussions around this. So what do you see? And I'm going to pose this first to Monica, and then Pan, I'll ask you your insights on this. What do you see are both the strengths of each of these types of measures, but also the limitations that come along with them? Monica, I'll start with you.
So first of all, I would like to say what we mean with subjective and objective, because probably there is not such as an objective measure, especially when we look at competence and performance, because the only really objective type of outcomes that we can measure is with tests, right? We do pre-post tests, multiple choice questions, knowledge-based or case-based. So this is the real objective one. But then when we talk about competence, you have always a subjectivity, because you have an assessor that is a subject and the learner that has been assessed. But let's say we call them objective in a sense that you have a measuring tool and you have a score that you can associate with that. And so let's say the advantage of objective is that you have a scoring system, and you have a number that comes after that, and you can see, okay, it's improving or not. However, the limitation is really that it's time consuming to create those assessment measures. I mean, we can discuss hours on how to get a good multiple choice question with Pan and so on, but it's really difficult to measure good tools, to create good tools, and they have to be validated. So this is a little bit. For the subjective, I will call it more self-reported. At least this is how we use that, and I mean, of course, they are subjective. So it's asking, for example, did you learn something new? To the learner. So for me, they are very easy both to create and also sometimes also easier for the learner to. Yeah. So these for me are the main two.
Pan, do you want to add anything to that?
Yeah, I think it's really interesting, like to hear, like, Monica, how your organization has been kind of measuring competence, because I think there's different methods look like, because many provider right now, they measure competence also using kind of like a question, kind of, but it should be case-based. You describe patient case, and then people select one of the best option there, like treatment plan. So that's actually currently defined by many other provider how to measure competence. And then to add to that, like performance, right? There's like, actually, I think this conversation maybe is even more widely discussed in the performance setting, where subjective measure is self-report of behavior change, and objective measure is those kind of analysis using claim data, like or patient charts, something like that. And my overall impression of this whole discussion is, I think it's much needed, but the way we're discussing it is only scratching the surface. It's usually general belief is subjective measure it's better because it be easier to use. That's about it. We stop there. And we say objective measure is more objective, but more pricey, more expensive to do. There are much more about that, the comparison between the two. For instance, subjective measure, when we talk about performance, it can be used to measure many things that objective measure cannot capture, such as multidisciplinary care and patient-centered care. Those it'd be very difficult to capture in objective measure. In addition to that, it can help you to capture many kind of the process that lead to the performance change, such as perceived barrier, confidence. It can also help you to capture greater depth into the practice pattern of the behavior you're interested. So I feel those strengths of subjective measure have not been adequately discussed. On the other hand, even though there's a trend in using objective measure performance, its limitation has not been adequately addressed. So for instance, the limitation on the type of behavior we can measure using objective measure. It's focusing a lot about diagnosis and treatments, but less about other clinical behaviors we want to measure. In addition to that, it's, as you mentioned, Celeste, it's more challenging to adopt outside US versus in the US.
Yeah.
And lastly, also, it's important to acknowledge the amount of resources it would take to analyze this data, not just to analyze it, but to analyze it properly. It's huge. So if we really want to do a good job in analyze those data, it may not even be practical and feasible. So overall, I think the emphasis should really be less about which approach we're taking, like subjective or objective, but more about how we're applying it. We need to assess whether we're applying those approach properly so we can get data with the insights that can help shape better education.
Yeah. And we could go on and on about this because, and that does lead into sample size questions and what's appropriate and all of those issues. And again, I think those will be addressed more in the larger group at ECF. But, we're talking about all of these, how do we measure? And I think for most of us who have been doing this for a while, we certainly have the concepts around, and we have some people who are very professional around this. And I'm looking at our time here, so I think we're going to have to kind of move along. But one of the questions that continues to come up, both came from our audience, and also we in the Good CME practice group talk about, you can have the best way to measure something. You can have all of these techniques down. You can have all the theories down. But the challenge is, how do we get our learners, healthcare professionals, to engage beyond their immediate learning experience? So, for example, I know that we've always had the challenge. We have so many healthcare professionals that will complete an activity, but when it comes to the follow-up, where the evaluation comes, or the motivation is not there, as we've been told over and over again, to receive a certificate or to get accreditation. Those are our challenges, is how do we get this data to from in these activities? So I think Monica, I'll start with you quickly here, and then Pan, I'll ask your feedback.
So, it is challenging. We have, if we have 50% response rate, we are happy, but it really depends on the activity. For example, if you have 3 days course, maybe the strategy is to have the last 10 minutes to have an outcome, so to have an assessment. So making it part of the educational activity, because the assessment is part of the learning. And having faculty, the faculty to push the learner to do that. But this is for courses. When you have online activities, maybe one way could be to give feedback to the learner about how they compare to their peers. So that is kind of giving them a self-assessment also, how are they doing themselves, because sometimes it's only one way. They give the answers and then they don't hear what is the results. So that I think, and I will leave a Pan to add some more.
Yeah.
That's great. Yeah, great suggestion. And I completely agree that's the effective approach. And in addition to that, I think having better quality question that is more readable, kind of not difficult to interpret, and that is aligned with the content, but also help engaging HCP more. And the other thing we need to ask is if we're not seeing that answering the question why that's the case. I think there's two things. First, they may not be as interested in answering question, although they may still be interested in learning. And secondly, they may not have time. So with that in mind, I think it's important for us to kind of consider maybe not forcing them to answer the questions throughout the education, but that also means we may need to find a way to kind of collect data outside education. I understand that that's going to require more resources. So really for organizations who have the resource to do so, maybe you can consider doing that and you may get better high quality data, right? And you can actually ask more questions if you do that way.
Yeah. I did have more questions for both of you today, but we are running out of time. So I'll go very quickly and ask you if you, in summary, if there was one piece, one tidbit of information you'd like to leave with our audience today, what would that be? Pan, I'll start with you. You've got 1 minute. Go ahead.
Yeah, okay. Quickly. So I think we need to focus more on insights versus just the impact. And also we need to pay more attention to data quality versus just data quantity. So if we can start doing that, I think we're going to really gradually maximize the potential of our outcomes.
Perfect. Monica, what's the one tidbit you'd like to leave with our audience today?
So for me, it's very important to make sure that you that the outcome levels that you choose is fitting the learning outcomes. So focus on the learner needs, what you want to achieve, and then you choose the learning outcomes. Not go I if it's not possible to do.
Okay. So again, I want to thank you both very much for your insights. I think you both brought some very interesting choices. Obviously, Monica working in one type of setting over in Europe, Pan working more in the Americas, but also kind of with a different type of organization and working across an international base. And again, I think that this discussion could definitely go on we could talk about this for days. And I will invite everyone to join us we will all be there at the European CME Forum in November, the 5th through the 8th, I believe are the correct dates in Madrid. And please make sure to sign up. I'm going to say goodbye to everyone, to our audience today. Goodbye to Monica and Pan.
Well, it seems that 30 minutes wasn't quite long enough to address all the questions that were asked during the webinar. So we asked Celeste, Pan, and Monica to stay online for a little bit longer to offer you this bonus content.
So the first one, I think that we answer regarding the self-reported outcome. I mean, we didn't cover completely because it's self-reported outcomes is highly dependent on quality of the input. Busy HCP are not always interested in doing the pre and post test, and the same for post test. Also, time to do the test is on average very short. Again, pointing to the rush answering procedure. Yeah, but they even don't do it, right?
Yeah, I agree. And as a matter of fact, I work with people with clinical background who had a PharmD or MD degree, and they say like sometimes they just when they see question, they just click it, they just check it, and then so they can move forward. So that's actually one of the reasons I think it's about time for us to think about whether we need to force people to answer the question in order for them to access the education. Because it not only prevents people who are interested in participating in education, but not interested in answering a question to participate. Also, it decreases the quality of the data as well. So really, and then finding resources. I know it's very difficult, but maybe if we can demonstrate the needs in our community, maybe we can get more support and resources in doing that. Like really collect data separately from the education. That could be done, but it definitely would be more costly to do so.
I think the other issue too is, and I think this is where kind of the education has to come around to, is quantity versus quality. And you started to touch on that, Pan, and I think that that's really important. And I think that a lot of people want to see huge numbers. You know, they want to see, you know, oh well, you got all these people educated, and I think you either have a choice of, to your point, getting people to start the education and stick with it because they're really interested in the education. And maybe, you know, that's always the conundrum that we face. Do you force people to answer questions before they can start the education? And we've seen that the drop-off rate, if you, and I think you saw this as well in your you know, your research, the drop-off rate for people to, if they have to have some sort of a question as a barrier, is huge. People don't even start the education if you put, you know, if you put the questions up front, because there is, for better or for worse, a plethora of educational options out there for them. And so they will go for the one that's the quickest and easiest, you know, unless they're like you, in your case, Monica, if somebody joins a course and is really involved, it's a different being, you know, but even you have issues to try to get people to complete the work. Yeah,
I mean, for a course, it's easy because they don't get a certificate of attendance if they don't give us the evaluation of the course. So, I mean, that is what, but that is possible only if you have this system. But when we do online learning, forget about it.
Yep. Yeah, I mean, it is a challenge, and I think, and I'm glad, Pan, that you brought up on a couple of occasions about, you know, the education versus the, you know, the measurement, the outcome, because we, you know, you and I had that conversation. People are so worried about what the measurement is, we kind of forget what the, you know, the value of the education.
It's interesting because this relates to the second question from Joe, and I think I'm going to chat with her. Because I think I agree somehow with her kind of perspective, but what I meant is not about privileging education over outcomes. It's about prioritizing and acknowledging we are kind of constrained on resources. I think my major point is we don't want to kind of prioritize outcomes too much so it impact the quality of the education. There's always a balance when the money is fixed, right? When you only have this much resources, then you have to decide to what extent can you allocate resources to outcomes without jeopardizing the quality of education. So that's my key thing, is that what is optimal balance. But I agree with Joe. Like, I think she meant is really, we have a lot of opportunity to learn from outcomes, right? Because if we don't have those data, then we cannot learn, we cannot improve. I completely agree. But we also need to be cautious about like how it could impact, the resource could impact our education quality as well.
But again, it is, I mean, we cannot always measure, and it depends the type of education that you're providing. Again, you cannot always have contribute to change with a 5 minutes education. What is the contribution to a change? Maybe, yeah, it is contributing, but how can you measure that contribution? You have to be realistic. It really depends on the type of education. If you have, for example, a simulation, right? You're teaching a technical skill. You can measure whatever you want within the system. Is there progression? Are they learning how to do it? But then even there, to go back to the patient and the transferability of the skills. I mean, huge resources. There are research projects with budget allocated to it, and you cannot do this on a daily basis.
Yeah, I absolutely know.
So you prove the concept with one case, and then you expand it, and you hope that is true for all the other activities.
Yeah. And again, a lot of the times the education that we receive, to your point, Monica, a 5-minute piece, it's very hard to measure the impact of that now, but we don't necessarily know a week down the road, five months down the road, you know, what happens. You know, somebody may get that 5 minutes, remember it, and use it 5 months from now. And, you know, we're not there to measure that, but we have affected a change. We have, you know, and I kind of firmly believe that sometimes the things that affect our change and you know, we learn the most from aren't necessarily the things like a course or something that we're going to do. And we know that that's helpful, but it's oftentimes those little pieces that build up that make, you know, that allow us to put something into our, you know, into our practice, into what we do. You know, and it's not just healthcare professionals, all of us.
And sometimes we have to consider the best moments in which we call them teachable moments, right? Because in that moment, maybe you remember, oh, there was this resource that I saw 2 months ago where they were saying exactly this. You go back and you, again, review what you, in theory, learned already, but you just remember in the back of your mind that you have seen that. So
it's the aha moments that,
yeah.
You know.
Yeah.
This is what it meant. This is how I can use it.
Exactly.